right, I'm gonna share by sharing my screen. First of all, I just want to say welcome, everybody. Thank you so much for being here today. I'm excited for this talk. If you're new here, this is part of the Global Organization for Wilderness Medicine Education lecture series. So our mission of what we do here is basically just to help expand educational interests and knowledge base for people who are looking at specifically wilderness and emergency medicine, but wilderness medicine obviously has got a pretty big, diverse name, and lots of things can go underneath that. So we, kind of fit any number of things underneath that. I'll let you guys read the specifics if you're really excited. So if you're excited about these lectures, if you're interested in learning more about other things that we do, getting involved, if you're if you're a person who thinks you have a lecture that you really are excited about giving, this is a way to join our mailing list, hear about what we're doing, and get in touch with us. We encourage everybody to join. This is another way you can get in touch with us. We're on almost all of the various platforms. Also, if you are interested in seeing lectures maybe that have already happened that you couldn't go to, they're on the YouTube channel, and you can watch them all there. Or if you see one in the future that you can't make, you can find it there later. So this is actually not. All right, so this is our board of people who do things. And this is like a multi-pronged approach, and lots of people do lots of different things. And there's an opportunity every year to join our board if people are interested. That will happen later in the winter time. So without further ado, the exciting part of today is that I'm excited to introduce Dr. Olivia Pearson. She is originally from the Northeast, went to school in medical school in Maine, is now a resident at the University of Utah in emergency medicine. I actually had the pleasure of hearing this lecture, and I was like, this is a great lecture that other people should hear. And so I reached out and asked if she wouldn't mind showing. And one of the best fun facts about Olivia, she's got this amazing dog named Wyo pictured here in the forefront. So thank you so much, Olivia, for being here. And I'll stop sharing and I'll let you take it away.
All right, thank you so much, Valentina. I'm gonna go ahead and try and share my screen. I think I might just need access to do that, it looks like. All right. Okay, can everybody see my screen? Okay. So, okay. Thank you all so much for having me. I'm going to give you my presentation called Toxicology ABCs, which obviously stands for ants, bees, centipedes, and spiders and scorpions. Some disclosures up front. I have absolutely no financial disclosures, but I do love this podcast. So this is my favorite podcast. It's called Tooth and Claw. It's actually run by a few folks who are from Salt Lake City and a couple of whom still live in Salt Lake City. It's all about real life animal attack stories and how humans interact with wildlife in their environment. It really promotes wildlife conservation. And I just have really enjoyed hearing about all of their stories. So I decided to draw from some of their episodes and use it as inspiration in this presentation and hopefully make it a little fun. So we are first going to be talking about Hymenoptera. So this is our first case. It's called Fire in the Hole. So this here is Joan Murray. She went skydiving in North Carolina in September of 1999 when her first parachute failed to open. She was plummeting about 14,500 feet when this happened. She remained calm, attempted to open her second parachute at about 700 feet from the ground, but unfortunately she was so disoriented from spinning so much that she actually got tangled in the cords, the parachute deflated, and she continued to fall, plummeting it to the ground at around 80 miles an hour. She ended up sustaining comminuted pelvic and femur fractures, had several teeth knocked out. She broke some ribs. She had a pneumothorax. She remained conscious throughout her entire fall, which is absolutely terrifying, and did not sustain any major head trauma. She ended up undergoing about 20 reconstructive surgeries, 17 blood transfusions, and was sedated for about 2 weeks. So the real question is, how on earth did she survive? So as if she already wasn't having a just super unlucky day, she ended up falling onto a mound of fire ants who ferociously began stinging her. She was stung over 200 times before paramedics arrived at the scene. However, this might have actually been the thing that doctors theorized kept her alive when she otherwise would have died after such traumatic injuries. They theorized that the stimulation and pain from these bites actually contributed to an adrenergic response that ultimately kept her heart beating. Unfortunately, this happened over 20 years ago, so I don't have a lot of access to a lot of the original documents from that time. But it sounds like her doctors were pretty convinced that had she not fallen on this anthill, she likely would not have survived. So we'll talk a little bit about fire ants. There's about 5 known species of fire ants in the United States. They inhabit loose dirt with one mature nest producing about 200,000 ants in a 3-year period. They tend to swarm when they're provoked and attack in great numbers. They position themselves on their victim and sting simultaneously in response to an alarm pheromone that's released by one or several individuals. So when they sting somebody, they actually release a pheromone, and other members of their nest are actually attracted to that signal and then will head in that direction and try to sting in the same area. And this is why it's so easy for immobilized or elderly patients to become rapidly covered by swarms, and they can usually suffer multiple severe stings and sometimes even death from these events. Fatalities and other severe reactions have been reported to occur rapidly following single stings from ants, but most occur in patients not treated with epi who have a history of prior venom allergy and prior cardiopulmonary disease. There's also been reported cases of rhabdo and renal failure, and it's estimated that the hypersensitivity of the general population to fire ants is about 16%. Something we'll talk about a little bit further on is that the possible cross-reactivity occurs between fire ants and other members of Hymenoptera. So if you are allergic to fire ants, there's a potential that you could be allergic to bees, wasps, hornets, and those kinds of things as well. These pictures here highlight a couple of the reactions that we'll continue to talk about. The one on top is a local reaction. It kind of shows a small pustule with some erythema surrounding the base. And the picture below is actually from one of my lovely co-residents who let me use this photo of a sting she got a few weeks ago. And it shows a large local reaction with much more induration, some erythema, and according to her, a decent amount of pain as well. Okay. This was just a quote from Joan Murray, the subject from our first case. She sounded like a really incredible human being. Took her about 2 years of rehab to fully recover from her fall. She worked for Bank of America at the time, and they actually offered her an early retirement package, and she declined it, wanting to continue to work for them for the next 20 years or so. And she actually ended up passing away 2 years ago from cancer. So she just sounded like a really exceptional human being. And she actually went skydiving again a few years after this incident. So I just kind of wanted to highlight her for a moment. Okay, we'll move on to our second case, another story from the podcast. And I've called this one A Force to Be Reckoned With. So in May of 2015, Doug April and Ian Capelli were heading to Hueco Tanks, Texas to do some climbing. They selected a route called Indecent Exposure, which was a multi-pitch climb that consisted of exposed 130-foot drops and is outlined by those red lines in the photo. They had completed their first pitch. They were about halfway up the wall on a ledge that was about 2 feet wide when Doug decided to start leading their second pitch. So in order to do this part of the climb, which was the hardest part of the climb, he had to climb up 10 feet and out to the right about 25 feet. Most difficult part of the day, and he actually did it quite well and was thinking to himself that they were having a really fantastic time. He shouted down to Ian and he said, "That was great." And then the next thing Ian remembers hearing him say was, "Where are all of these bugs coming from?" So what had actually happened is in the crack of the rock, there was an Africanized honeybee nest. And what happened was when Doug was climbing, he actually irritated this hive. And unfortunately, these bees all came out and began to attack him. So Doug started immediately screaming down to Ian to lower him to the ground. Ian started lowering him. He wasn't able to lower him all the way, but Doug was able to unhook, attach himself to an anchor, and then rappel to the bottom by himself. Unfortunately, while this was happening, the bees turned their attention from Doug towards Ian, who was stuck halfway up the wall on this very narrow ledge. Ian actually recalls saying that he could see the first bee coming towards him, and he remembers thinking to himself, if I just stand still, maybe it won't see me. Which is a really great method if this was a T-Rex from Jurassic Park, but unfortunately for bees, this is not a great method. It does not work very well. And he began being stung pretty rapidly by the swarm. Doug actually recalls looking up at the ledge, and he could see the carcasses from the bees that had stung Ian just kind of water falling off of the ledge, which sounds pretty terrifying. Doug ran to the parking lot where he encountered a few hikers that had some wilderness med experience, and they called first responders while he decided to hike up the backside of this climb, rappel down, grab Ian's body, and then rappel him down to the ground. And by the time they reached the ground, they actually had first responders arriving on the scene to help care for Ian. He was transported to the hospital, treated overnight, and very luckily was released the next day. Doug, meanwhile, still had a few hundred stings on his body. And what was really interesting is the folks who had wilderness med experience gave him this really useful tip to use credit cards and his fingernails to help remove the stingers to avoid injecting more of the venom into his body. And this actually worked quite well for him, and he did not need to seek medical care. And for any Arrested Development fans, I could not leave out this favorite meme of mine. So a little bit about bees and wasps. The sting apparatus consists of a motor, piercing, and venom parts. The motor is actually this muscle in the stinger that is constantly squeezing out more venom into the wound. The piercing portion is the stinger with some barbs on them that actually will lodge themselves in mammalian flesh. And it's actually ripped out of the bee when it stings you, which is why bees do tend to die after they sting a person. If they were to sting another arthropod, those barbs actually don't tend to hold pretty deeply into that tissue. So the myth that a bee will always die after it stings is actually incorrect. They might actually live if they sting another arthropod. All Hymenoptera share similar components of their venom. It's a very complex mixture with many different compounds, which include proteins, peptides, phospholipids, sugars, biogenic amines, volatile compounds, pheromones, and a lot of water. I highlighted a couple of the really important ones. So melodin is the main and most toxic compound. It causes the degranulation of basophils and mast cells. And then phospholipase A2 combines with melodin and actually cleaves cellular membrane phospholipids, and this can lead to hemolysis. About an average of 140 to 150 micrograms of venom is delivered in a single stinging event. It's hard to quantify, but a lot of the sources that I found used as an example, roughly 10 bites per pound can cause systemic effects in a person. So you can imagine for a child who doesn't weigh very much, it actually doesn't take many stings for them to feel some effects. The bees in this story were Africanized honeybees. I think they have a really interesting history, which I'll touch on just a little bit. There was a scientist in Brazil in, I think it was 1957, who had this idea to kind of create a hybrid, a new species that essentially would have the honey production that a European honeybee has and would be able to withstand hot temperatures like an African honeybee is able to. So he decided to breed these two together and then created Africanized honeybees, which he thought would be his perfect species for that climate. Unfortunately, a worker was at the facility where they were created one day, and they had put up a blocker that would prevent the queen and the drones from leaving the hive and then sort of spreading throughout the area. And unfortunately, removed that blocker, kind of allowed the hive to spread, and that is now why we have Africanized honeybees. The reason that I bring this up is they tend to be significantly more defensive than a lot of other bee species. Bees will send out maybe 8 to 10% of their hive in the event of an attack, whereas Africanized honeybees will send out about 100% of their hive. This can lead to a massive stinging events, multi-system damage, and death from venom toxicity as well. So for evaluation and management of stinging Hymenoptera, I previously discussed there's a couple different reactions. You can have a local reaction with just some local pain, erythema, some swelling, some large local reactions that can increase in size over a few days and then resolve about 10 days later. And then we can have systemic reactions, which are similar to anaphylaxis. And you can have urticaria and angioedema. Most reactions develop within the first 15 minutes, and nearly all will occur within 6 hours. A lot of folks will have more systemic symptoms like nausea, vomiting, diarrhea, syncope, and some muscle spasms. Some severe cases have reported respiratory distress and cardiac arrest, as well as renal and hepatic failure, DIC, and rhabdo. And then a point that I really want to drive home is that these systemic toxic reactions are characterized by the sheer amount of venom that's being injected into a person's body and the actual toxic events of the venom. So this is different from folks who are stung by one bee and end up suffering an anaphylactic reaction. That is a type 1 IgE mediated hypersensitivity reaction. So that is separate from a lot of these stinging events where it's just the amount of venom that is injected is directly toxic to a person's system. So really important for us as providers or future providers is the management of these events. It's really important to immediately remove the stinger. It's best if you can use a credit card or your fingernails to scrape out the stinger. If you were to grab it with a tweezer on top, you can actually inject more venom into the wound. So you want to avoid that by scraping it out at the base. But really by whatever means necessary, it's just important to get these out as quickly as possible. Local wound care and tetanus prophylaxis is pretty much going to be a catch-all for all of these events that we're talking about today. And then antihistamines and NSAIDs for pruritus. Insect repellents were actually found not to be as effective as wearing socks or cotton tights, specifically when talking about fire ants. So really sort of a mechanical protection is important there. And then in systemic reactions, importantly, we want to treat for anaphylaxis. A 60 to 70 kilogram person has a 50% chance of death after about 1,000 bee stings, but deaths have been reported after 200 to 300 stings. Regardless, patients should be evaluated after about 50 plus stings. That's the advice of our poison center here in Utah. And Ian in our story, they believe had between 1,000 to 1,200 stings. So he did have about a 50% chance of mortality in this encounter. And we always want to consider admission for those who have a substantial amount of stings, significant comorbidities, or are part of our elderly population. This was a headline that I actually just found when I was doing my research of a man in Texas who was killed by these Africanized honeybees. He was out mowing, he was a farmer and he was out mowing his field and ended up encountering a hive of these bees. They started swarming him. He ran to get help, but unfortunately he succumbed to his wounds. As temperatures are rising, these bees have they originated in Brazil and they've been moving northwards ever since. So I anticipate we'll be seeing them in a lot more states in the next 5 to 10 years. Okay, we'll move on to our next group and we are going to talk about just a couple of spiders. So Latrodectus widow spiders have a worldwide distribution. The most well-known in the US is, of course, the black widow spider, characterized by an orange-red hourglass-shaped marking. Females are typically larger. Their body size is up to 1.5 centimeters in length, and their leg spans usually about 4 to 5 centimeters. They're quite large. Males are smaller and their bites can't penetrate human skin, so they are completely harmless. They actually got their name because they are cannibals during the mating season, so the females will actually consume the males. They're most often found in wood piles, basements, garages, and sheds. The top picture is actually a photo that I took of my life jacket last summer. I spent about a month in New Mexico and I had left my life jacket in next to a wood pile in the backyard. And then I actually carried it under my arm to my car before discovering that this little gal had hitched a ride. And it's the first time I'd actually seen one in real life. And I will say they are quite beautiful and certainly quite large. Most black widow bites in the US occur between April and October. They're usually on the hands and forearms. They aggressively defend their webs, particularly when guarding eggs, but otherwise, if you don't bother them, they generally leave you alone. You really have to agitate these guys for them to want to get mad enough that they're going to bite you. They are the most venomous spiders in North America. The most active component of the venom is alpha latrotoxin, which acts through both calcium-dependent and calcium-independent pathways, leads to receptor stimulation, pore formation, and a massive release of acetylcholine and norepinephrine. Acetylcholine release accounts for the neuromuscular manifestations, and norepi release accounts for the cardiovascular manifestations of these bites. So black widow bite management, similar to our Hymenoptera, we can have local, regional, or generalized pain associated with systemic symptoms. And there's also autonomic effects. Most bites are felt immediately as a pinprick sensation at the bite site, following by increased local pain that may spread quickly to include the entire bitten extremity. Erythema appears approximately 20 to 60 minutes after a bite. In smaller bites, about less than 5 millimeter erythematous macule develops that may evolve into a larger target lesion with a blanched center and surrounding erythema. The clinical syndrome of envenomation is referred to as lactrodectism. It involves cramp-like spasms in large muscle groups. There's no rigidity on exam. There's diaphoresis near the envenomation site. Pain becomes generalized, and patients experience severe abdominal wall musculature pain and cramping as well. Vital sign abnormalities include hypertension and tachycardia. There's rare complications that have included AFib, myocarditis, priapism, and death. Pain appears by several hours and disappears by 2 to 3 days. Just a little caveat about death by a black widow bite is I've done a lot of research on these spiders, and it's actually very difficult to find a case study where there is a confirmed death due solely to a black widow. I talked about it with one of our poison control center folks here as well, and he agrees that there hasn't really been a case where a black widow directly caused the death of a person. It has happened in situations where people have really severe comorbidities and this bite potentially pushed them over the edge, but their death was not solely due to a black widow bite. Management of these bites always involves local wound care, analgesia, and tetanus prophylaxis. You can consider opioids or benzos for pain. We do have an antivenom called antivenin. It's indicated really only for systemic illness. It is very highly effective, and it will completely treat symptoms within 1 hour. There are, however, some downsides to antivenom that we'll discuss just a little bit later on. So keep that in mind when you're thinking about treating patients with this medication. Consider admission for adequate pain control. And then things that are not indicated are routine antibiotic use and IV calcium gluconate. There was a study that was done, and it actually found calcium was ineffective for pain relief compared to a combo of opioids and benzos. So it was recommended at one time, but is not recommended any longer. And now we'll just move on very quickly to some brown recluse spiders. So they occupy South Central and Midwestern regions for the majority, and this is where the majority of significant envenomations occur. They are identified by their eye pattern, which consists of 6 paired eyes, and they appear kind of as 3 dots, if you can see in the photo below. And this is one really easy way to distinguish them from a lot of other spiders. Their venom also contains multiple enzymes, one of which is hyaluronidase. It's responsible for fast distribution of the venom by disrupting the extracellular matrix and allowing the venom to spread to other tissues. There's also sphingomyelinase D, which is responsible for necrosis by causing the release of some pro-inflammatory markers. Significant necrotic wounds are rare, but possible through neutrophil activation, platelet aggregation, and thrombosis. But the perceived threat of these spiders far exceeds their actual danger, kind of similar to black widows. Management of these bites. So they're initially described as painless. Most common manifestation is a mild erythematous lesion that may become firm and heal with little or no scar. Some experience a more severe local reaction with a hemorrhagic blister that progresses to necrosis and eschar formation, as we can see in the bottom photo. A necrotic, slowly healing ulcer may not reach maximum size for many weeks after envenomation. The photo on the top was about 4 days after a bite from a brown recluse, and the photo on the bottom was after about 9 days. So in a span of 5 days, this sort of change in the characterization of this wound took place. Systemic effects rarely occur, but can and consist of nausea and vomiting, fevers and chills, arthralgias, thrombocytopenia, rhabdomyolysis, hemoglobinuria, and renal failure, but DIC and death are also very rare. So management of these wounds, obviously local wound care. Antibiotics can be indicated, but only if there are clinical signs of an underlying infection. In the US, there's no commercially available antivenom. If wound ulceration develops, the plan of action is to refer for surgical debridement and follow up for skin grafting. You can usually send these folks home unless it's a small child that's showing signs of systemic toxicity, and then you want to think about admission. And then something that is not indicated is dapsone. There's been a number of different medications that have been studied to help treat brown recluse bites, including antihistamines, antivenom, colchicine, hyperbaric oxygen, but really none have clear benefit, and most of these wounds are self-limiting, so we really don't have to go too overboard in treatment. Just a very quick note on tarantulas. I'm sure many of you know what tarantulas are, but they're large hairy spiders that are quite popular as house pets. They have hairs that cover their abdomen, and what they will actually do is when threatened, they flick using their back legs, some of this hair from their abdomen forward as a defense mechanism. And this is actually the most dangerous part of tarantulas. These hairs can embed themselves in the conjunctiva and cornea, but rarely penetrate the skin. So if you have someone come in who has a pet tarantula and has gotten some of the hair in their eyes, you would want to consult ophthalmology, as treatment can occasionally require surgical removal. If there's ever hairs that actually are embedded in the skin, you can use duct tape and then just irrigate the area and it should heal up quite well. The mild-mannered North and South American tarantula species produce a bite similar to that of a Hymenoptera sting, but it's not been shown to have any systemic toxicity. The photo below is from a movie in the 1950s called Tarantula that I haven't seen, but I just wanted to put this photo in here because I think there's a number of different animal species that have really gotten a bad reputation from a lot of TVs and movies and books and pop culture. And just in doing my research for this presentation, it's actually interesting to find that they're not quite as deadly or as dangerous as we have been taught to believe. Maybe just a little bit creepy or scary to some, but I did just want to highlight that. So we'll move on to our next group and we'll talk briefly about the Arizona bark scorpion. So there are several species of scorpions found in the United States, but only one species is neurotoxic and can cause systemic toxicity. Most species just cause localized pain. It's a really small scorpion. It's only about 2 to 3 inches long. It's nocturnal and they glow white under a black light. I think there's a lot of folks in the Grand Canyon area that will actually go out in the dark with black lights to try and search for them. They're found in different parts of the United States. I know they're found in southwestern Utah. Their chemical makeup of their venom is quite complex as well, but one important component is a heat-stable and protease-resistant neurotoxin, and infants and children are at the highest risk for severe systemic symptoms from these guys. Their toxins open neuronal sodium channels, and they actually cause a prolonged and excessive depolarization, which leads to catecholamine and acetylcholine release. So this is a photo of one of the scorpions under a black light. So you can have different grades of reactions, and you can definitely look them up. They're really interesting, sort of how they distinguish one grade from another, and then how that kind of helps manage treatment options. So grade 1, local reaction, there's pain and paresthesias near the envenomation site. You can have systemic reactions. It's really uncommon, but infants and young children are at high risk, especially since these folks are very curious and might be playing outside and accidentally come upon one of these guys. But less than 10% of stings result in systemic toxicity. Motor hyperactivity is nearly universal when symptoms are systemic and presents as a restlessness or uncontrollable jerking. You can have cranial nerve palsies that lead to oculomotor dysfunction, tongue fasciculations, hypersalivation, a loss of pharyngeal muscle control, which can lead to the patients being unable to protect their airway and lead to intubation within the emergency department. There can also be a significant amount of cardiovascular toxicity, and you will see tachycardia, hypertension. They can develop pulmonary edema and then shock, which are the most severe symptoms. Management for these wounds is local wound care, of course. You can give atropine for the hypersalivation and respiratory distress. There is Anascor antivenom. It's only available in Arizona, Nevada, and Utah. It is a very expensive antivenom. It does appear to be effective in reversing many of the manifestations of envenomation and appears to improve mortality, but it's not effective in reversing any already established cardiac damage. Prazosin can be given to counteract the adrenergic effects, and dobutamine can be given to support some cardiac function. Other supportive care is always involved, like giving IV fluids. And then grade 3 or grade 4 likely require antivenom administration. I do have a video. I'm not quite sure if this will work, but I will give it a try. Let's see. Can you see the YouTube, or are you still seeing the presentation? Okay, let's try this. How about now? Great, okay. So I'll just show you very briefly. This is a child that had an encounter with one of these scorpions.
That is really frightening. They have a set of symptoms that comes from all of the different nerves of the body being kind of stuck in the on position simultaneously, and all of their muscles lose control, so that there may be one twitching and one jerking and a little inhalation and a little exhalation all at the same time. When you put it all together, they don't breathe very well.
Okay. Right. Okay. All right, so a very quick word on centipedes, because my ABCs mnemonic would not have worked without a C. They belong to the class Chilopoda, and there's over 8,000 known species worldwide. They live under soil, rocks, logs, and in caves or in human dwellings. All centipedes are venomous, so should we be scared? And the answer is no. Some species can grow to be about 1 foot long, and bites cause mild systemic symptoms. But based on studies, the venom doesn't contain any lethal factors. And you would have to probably get stung by hundreds or thousands of these guys for there to be any systemic effects. And because they are quite large, that is highly unlikely. It would usually take over about 1,000 bites to cause death in a human. The one on the bottom here is called the Texas red-headed centipede as well. And then a very quick word on pest caterpillars. They're found in the southeastern US and they account for most of the serious envenomations from caterpillars. They were given their name because some think they bear a striking resemblance to a cat. They have these venomous spines beneath their hairs that can become embedded in a person's skin. When stung, you can experience intense local burning pain rather than pruritus. And then there's usually these papules that erupt in a grid-like pattern about 2 to 3 hours after exposure. You can also have some local swelling and lymphadenopathy. There have been reports of systemic symptoms such as headaches, fever, hypotension, and convulsions, but this is quite rare, and usually people do really well with symptomatic and supportive treatment. And then a quick word on antivenom adverse effects. So when given antivenom, there can be mild injection site pain and muscle cramps associated. Some folks will experience a hypersensitivity reaction. Antivenom is contraindicated in any folks who have ever experienced an anaphylactic reaction or atopy for this reason, because there is a chance of anaphylaxis in this patient population. Antivenom and Anascorp are both made from equine plasma, so there is the risk of serum sickness, which is a type 3 hypersensitivity reaction that's secondary to the administration of this heterologous protein that our body views as foreign. It can experience fever, urticaria, arthralgias, lymphadenopathy, splenomegaly, and eosinophilia as a part of this reaction. Usually you'll just want to stop giving someone the antivenom if you are continuing to administer it, and symptoms tend to improve as the immune system begins to remove the antigen from the body. Considering the side effect profile of these medications, the cost, and the relative toxicity of the animal, because as we discussed in some of the spider bites, systemic effects tend to be quite self-limited and rare. It's important to weigh the benefits and the risks of this treatment thoroughly with the patient before making a decision on whether or not you should be administering antivenom. Thank you all so much for listening. I sincerely appreciate it. I am obviously pursuing a degree in emergency medicine, but a big passion of mine is wildlife biology and human-wildlife interactions. And I always enjoy the opportunities where I can kind of mold together my personal and professional interests. So I really appreciate you all listening. Feel free to reach out with any questions.
Thank you so much for sharing that. If anybody does have any questions that they want to ask, we've got plenty of time. So either in the chat or just mute yourself. Also, thank you guys so much for coming and joining.